Can you please describe what you see in this video?
I can see an infant with moderate to severe respiratory distress with subcostal retractions, intercostal, suprasternal, and nasal flaring.
So, what is your diagnosis?
So this would be lower respiratory tract infection or viral associated wheeze.
Or anything you want to keep?
Foreign body may be there, but it usually the unilateral finding. I would like to give first. I would like to examine the child. If there is wheeze, I would like to start with salbutamol inhaler.
Wait. I have not asked. First of all, here I can see a child who is on home setting, average for age. The child is
Uh-huh.
on respiratory distress in the form of subcostal integral retraction. But at the beginning, while the child was coughing, the cough was barking like. Have you noticed that?
I could not. My video was not. There was no audio, so I could just see the
Okay,
video, not the audio. Yeah,
okay,
sorry about
okay.
that.
I understood. So the cough was barking in nature.
Okay,
On top diagnosis, it was actually Croup.
group. Yeah. Okay.
Yeah. So what is the organism responsible for Croup?
Uh, it's a para-influenza virus.
Yes, 6 months to 6 years. And
Yes.
we can keep the differential diagnosis group, okay, epiglottitis, bacterial tracheitis, foreign body, yes, anaphylaxis, any allergic
Yes.
airway disease, any congenital abnormality, laryngomalacia, foreign body, laryngeal papilloedema, subglottic
Yeah.
stenosis. You are telling viral induced, no problem. If you want to keep lower respiratory tract infection, no problem. So
Yeah.
suppose that is a group. What
Yeah.
history we'd like to ask?
So for group, I would like to ask the onset, progression, duration of the disease. Anyone else in the family having similar symptoms? And so yeah, basically, does the child goes to nursery where he could have contacted the
Okay.
disease?
So, as usual, in the history, we are asking onset, course, and duration. This is the differentiating point between the croup and laryngomalacia. We know
Yes.
that
Yeah.
laryngomalacia it started
Will be
like two
since
month
birth.
old. It is started,
Yeah.
and then 2 years it is gone away. And
Yeah.
croup actually 6 months to 6 years.
Yeah.
And then what increase, what decrease relation to feeding and sleep because sometimes aspiration,
Okay.
choking, gastroesophageal reflux disease we can keep. Then
Yeah.
fever, weight,
Okay.
activity, sleep as usual, any cyanosis or pallor, apnea, choking, drooling or missing any toy. As foreign body
Mm.
inhalation we are keeping. These are
Yeah.
COVID exposure and vaccine status, state of vaccination
Yes.
of the child, upper
Yeah.
respiratory any infections, chronic any illness, perinatal history, especially intubations.
Hmm.
After birth, any intubation, ventilation needed or not. These are the history asked. So how can
Okay.
you examine this patient? Suppose it is a group.
So, with croup, there should be a minimum touch technique for the child. So, because child should not be because it will worsen his disease. So, I will first do the inspection. First, I will take the vitals. What is the oxygen saturation, and how in which position the child is comfortable, and then I will proceed with my inspection and I will count the respiratory rate. Depending on the depth of recessions, I will divide it as whether it is a mild, severe distress, and also auscultation. With if in whichever position child is comfortable, I will do the auscultation and will get to know, and according to that, I will decide my management.
Okay. Investigations you want to do. Suppose group.
Yeah, yeah. So first, I would like to do a blood gas to know the PCO2 level, PO2 level, what is the pH, lactate, and
What you
I will
think
do.
that any blood gas? What do you find here? In group, any changes occur?
Yeah, so obviously PO2 will be less in this child, and so if there is a deep respiration with not much of tachypnea, then PCO2 buildup will be there. Raised PCO2 will be seen.
Okay, I'm telling you. Okay. First of all, examination is true that do not examine the throat and do not
Mm-hmm.
distress the child. Okay.
Yeah.
If I have any concern regarding examination or investigation, I will call my consultant urgently. Just I
Okay.
can take the vitals, oxygen saturations, consciousness level if cyanosis or chest retractions. Okay,
Mm-hmm.
don't need to yeah, auscultations, not going that. I will involve my consultant if I need to
Oh,
do any concern I have. Just
okay.
vitals, airway breathing circulations I am noticing, oxygen saturation level conscious or not, and cyanosis or not.
Okay.
Investigation, actually no investigation needed. Remember, in Croup, no investigation needed.
Okay.
Okay.
Mm-hmm.
Then how can we manage this Croup?
Um, So the management involves, first of all, there will be supportive management. So if oxygen saturation is low, I will give supplemental oxygen to the child. I will
Mhm.
maintain. I will make sure that child's airway, breathing, and circulation are intact. And I will start with adrenaline or dexamethasone nebulization.
Okay. So management, first of all, always airway breathing circulations. Then
Yeah.
according to mild, moderate, severe, and yes, we are giving the keep the child calm. So mild,
Mm.
moderate, severe. We need to know mild to moderate what happens some criteria. I'm telling that
Mm.
they will ask mild there is no any stridor at rest, no recession,
Mm.
no cyanosis, no alert. The child is alert and responsive. Moderate,
Okay.
what happened? There is stridor at rest, intermediate
Mm.
stridor present. There is
Mm.
mild recession, sinus is not present, and the child is alert and responsive. But what
Mm.
happened is severe. Severe, the child is stridor at rest.
Mm.
Recession, moderate to severe recession, child is sinused, oxygen saturation less than 92%, apathetic. Alertness is
Mm.
alterness is that apathetic and restless the child. So easily
Mhm.
mild is not at rest, stridor, moderate, intermediate rest, stridor at rest, and severe it at rest, that is stridor present.
Mhm.
And how can we manage that? Mild to moderate and the severe. Mild to moderate is analgesia adequate fluid I am giving. Oral dexamethasone dose is very important, 150 microgram per kg. Remember,
Okay.
oral
Mhm.
dexamethasone 150 microgram per kg can be repeated after 12 hours, or if the child is well, discharge on prednisolone 1 milligram per kg after 12 to 24 hours.
Mhm.
And if moderate, then admit and observe for 4 hours, then reassess. So
Okay.
mild we are discharging, moderate we are 4 hour observation. Then leaflet on group reassurance, no need to follow up of group. And advise the parents some urgently seek medical advice. What are the advice I am giving? Some drooling, if labored breathing, persistent
Mm.
fever, biphasic or worsening stridor, cyanosis, reduced level of consciousness. So easy. The condition is not improving. The child becomes cyanosed, breathing, respiratory difficulty increase, fever, then cyanosis, drooling is epiglottitis sign. A
Yeah.
severe croup, what happen we can do? Severe croup, that is keep the child first calm, then give high flow oxygen with via mask or reservoir. So high flow oxygen we are giving. Admit the child if continue more than 3 hours. The examination first we are trying 150 microgram per kg oral or nebulized budesonide. Then nebulized adrenaline to relieve the symptoms. Then if no response, I will consult with my pediatrician on call pediatric anesthetist in ENT transfer to the PIC. So
Okay.
first, severe I am moderate, mild is not admission needed. Oral dexamethasone 150 microgram
Dexamethasone.
per kg giving and discharge. Moderate, what
Mm.
happen? I am giving the 4 hour admit the child. Oral dexamethasone giving 150 microgram per kg. But some
Mm.
advice I am giving like drooling, biphasic stridor, worsening the stridor, fever, labored breathing, cyanosis. These are and
Yeah.
severe that is at rest. There is stridor. So in severe, I am admit the child first, then I am giving dexamethasone or nebulized budesonide, not improving, giving adrenaline, talking with my consultant, ENT anesthetist, transferring the child PIC. Okay,
Yeah. Yeah.
this is all about group video stations. So your history is